Good evening to all of you, and welcome to this Capdular webinar. So for this third English session about pain and surgery, we're very pleased to welcome 3 members of the IGOS group to share new case reports: Dr. Vincenzo Santoro, Dr. Takanori Sugiyama, and Professor Eric Viguier. So just a very few logistic points before we start. It will be 3 sessions of 20 minutes each. If you have questions during the lecture, don't hesitate to use the chat, and we'll answer as many as we can at the end of each session. So I'm now handing over to Victor Roballo for the presentation. So enjoy your lecture.
Hello to everyone. Thank you very much for your attendance, and thank you to the 3 lecturers who will present clinical cases around tarsus, tendon, and ligament reconstruction. In the order of the coming presentation, I am pleased to introduce you Dr. Vincenzo Santoro from Orthopedic in Italy that will talk about surgical treatment of tibiotarsal instability in a dog. Dr. Takanori Sugiyama from the University of Melbourne in Australia that will discuss complication of common calcaneal tendinopathy managed with Novaten. And finally, Professor Eric Viguier from the Veterinary School of Vetagro in France, who will showcase an Achilles tendon reconstruction on a goat. And Professor Viguier, if you are ready, we can pass to your conference. So you need to turn on your microphone.
Yes, sorry. Thank you, Victor, and thank you to the IGOS community, and also thank you for to Capdular to organize this presentation. So I will present you the surgical treatment of a ruptured Achilles tendon in a goat. I am a small animal surgeon, but before, when I was younger, I did large animal surgery until 1992.
Professor Viguier, you have turned off your microphone.
Yes. Next slide, please. This is a clinical case of goat who was presented last year to our large animal hospital for a severe lameness of the right in limb following a fall from a rack 3 weeks ago, and she's living in a small head. So next slide. The goat was in good shape, good health, and the orthopedic examination, not a severe lameness with splenomegalia of the right posterior. So this is not the slide of the picture of this goat, but is coming from a case I've seen in a discussion on the web, coming from Schilling of Alabama, and it was quite the same. At the palpation, we feel discontinuous Achilles tendon at the mid part and swelling, maybe 3 centimeters of swelling. There were no skin wound, and we saw to a chronic ruptured Achilles tendon because it was maybe 3 weeks, at least 3 weeks later. Next slide, please. On the X-ray, we didn't see at this time modification of the bone contour. We have no bone fragment, no calcification, and we have maybe modification of the density of soft tissue, particularly on the tendon. Oh, sorry. Next slide. On the ultrasound with for the imaging, we have seen some modification of hypogenicity and some heterogeneity of the flexor digit superficial tendon and in the gastrocnemius tendon. and it's like a scar. We have some connective tissue in this tendon, and it is the beginning of the bad repair. So at this time, we decided to repair and to do a tendinoplasty and do an augmentation with an artificial tendon. Next slide, please. For the anatomy is quite the same as dog, but we have a muscle who belongs to the gastrocnemius. This is the soleus muscle. It's a very small fibrous muscle, but he runs with the gastrocnemius. And you have the same anatomy with two parts for the gastrocnemius and the same aponeurosis. And the distal part, you have a combination of the caudal tibial muscle and the medial and lateral gluteal flexor muscle who gave the deep digital flexor tendon. And you can find also the superficial digit flexor tendon plus the gastrocnemius tendon. You can see the cross section on the picture on the right side. It's the same as the imaging you've seen before. Next slide, please. To prepare the surgery, we did a surgical planning and verify the length of the tendon and to choose the right artificial tendon and to prepare the material for the repair. And this is the modification of the flexion and max flexion while the knee has only a half flexion. So we have at least 5 or 6 centimeters of elongation. Next slide, please. For the surgery, first we do anesthesia protocol, a classic one for large animal, and the goat was placed under mechanical ventilation. We did the aseptic preparation like exactly the same as a small animal. Next slide, please. And we draped the animal and put an adhesive drape, and we palpated. We did a second surgical planning. At this time, I palpate the tendon, explain and feel some gap, and explain to my colleagues all the steps of the procedure to be sure that we will be well together. So next slide. The first thing is to do the incision laterally and a little bit caudally, particularly in the part of the belly of the gastrocnemius. We suture the polyurethane drape to the skin to prevent the contact of the prosthesis with the skin. Next slide, please. And after we do this, the dissection of the subcutaneous tissue and try to prevent the external saphenous vein. Next slide. At this time, we debride. Next slide, please. We do the dissection of the fascia and remove adhesion, and we split the tendon until the beginning of the gastrocnemius muscle. We debride all the adhesion and cut the tendon to obtain a perfect section of the tendon to have an easy suture after. So we calculate the length and flex the hook to be sure that it will be not too short after. Next slide, please. At this time, we first I decided to repair the medial part. I put the leg in the physiological position, verify the length of the tendon, cut if necessary, and do the first 3-loop pulley on the medial parts. Next slide. You have the side of the 3-loop pulley, and this is a part of the gastrocnemius with the superficial digit flexor. And after, next slide, please. I do the reconstruction of the lateral part from the gastrocnemius and the soleus tendon with a Kessler suture. And this part was thinner than the other. Next slide, please. Next slide. Oh, please. So, yes. At this time, I decided to drill the tunnel to prepare the passage of the ligament. Next slide. So we drill 2 tunnels, one coming from the gastrocnemius tendon to the distal part and mid part of the caudal part of the calcaneus, and the second hole perpendicular to the lateral face of the calcaneum. Be careful, don't do the 2 tunnels too close. You need at least 1 diameter between the both. 1 diameter of the screw between the both. And be careful on a young animal to drill not in the growing cartilage, because you can have an avulsion of the distal part of the calcaneus. Next slide, please. Next. So we put a polyethylene tendon. It's a ultra high molecular weight polyethylene. It's a Novaten 8000. And we use also a braided suture. It's a fiber tech. And we use also cannulate interference screw. These interference screws have been developed by Kurosawa. Kurosawa was a human surgeon, an orthopedic human surgeon who developed this interference screw. And really, next slide, please. We did many studies with this interference screw, and we have shown that we can have a very good fixation with this technique. So we decided to do this goat with this technique. So next slide, please. We put the synthetic prosthesis in the tunnel and pull. So the synthetic prosthesis was pulling out of the first calcaneal tunnel and then pull in the second tunnel with a wire pass. Next slide, please. So you see the synthetic prosthesis, but we didn't open totally the protection of the prosthesis to decrease contamination. And next slide, please. I put the prosthesis at this time between the 2 parts of the tendon, because we did a sagittal section, the mid diameter deep, and we put this suture until the belly of the gastrocnemius. We did some simple suture to fix the prosthesis and verify the length. The leg was always in physiological position. Next slide. And we do the fixation and do the proximal locking of the prosthesis with a continuous pattern suture with a braided suture. It's with the two metric fiber tech. My colleague Bastien Gouin has shown that the strength of this type of fixation has a very high strength, between 800 Newton and 900 Newton. So it's very strong for a goat. It's very strong. Next slide, please. This is a part of the specimen we have used during this study. Next slide, please. So we finished the suture, and we decide to fix the extremity of the ligament. We put the leg in the right position. The tibio-tarsal joint was between 160. The same for the knee. And we pull out the prosthesis and stretch enough to have the good tension, and we lock the distal prosthesis with the interference screw. Next slide, please. This is a picture we have at the end of the suture, and I verify always that I have enough screw in the lateral side and also screws in the medial side. I'll pipette the calcaneus in the medial part. Next slide, please. On the X-ray, you could see that the right emplacement, good placement of the screw, but on the under the tunnel. But on the lateral view, you can see a small fissure, a crack, because in the goat, the calcaneum is very, very hard. And we did, after the tunnel, we tap the tunnel to have the good shape and to have enough place for the screw and the ligament. But because of the hardness of this calcaneus, we had a crack. And really, I think it will be fine maybe to drill a little bit, maybe a bigger hole. I did a 3.6 millimeter, and maybe it will be fine to do a 4 millimeter in a wild animal like a goat, or I did also a surgery on deers when I did a long time, and really it's very, very, very hard, maybe harder than a dog. Next slide, please. And post-operative, we decided to use resin instead of external fixation or intern screw, a tibio-tarsal screw, because of post-operative. During the first week, the goat had anti-inflammatory and non-steroid drugs, opioids, and antibiotics. And we did an immobilization for 6 weeks. First, for the first week in extension with a cranial splint to decrease lesion of the calcaneus. And next slide, please. This is the goat 3 hours after the surgery. And she's under heat light. And at the second week, we did a bivalve resin in physiological position. Next slide, please. The animal was discharged at 15 days, and the client has to do a daily control of the resin and the skin, and to have a control each 10 days of the bandage by a vet, and the goat has to be maintained in a small goat enclosure during 4 weeks. Next slide, please. at 7 weeks, because of the poor respect of the rest and the bandage changement, we had a skin lesion, skin wound at the top of the calcaneus. So we had to readmit the animal in the hospital, do a limitation of exercise, antibiotic treatment, and do some dressing, non-adherent hydrogel, and we had a wound healing in 4 weeks. At week 14, the goat was discharged. Next slide, please. Next slide. On this picture at D51, we have a small periosteal proliferation of the top of the calcaneus, and at day 72, we had a resorption and condensation of this proliferation, and at day 97, we have totally bone healing of the crack, and we have no more periosteal proliferation. And we didn't have infection at this time. At the beginning, we have a skin infection, but not deep. Next slide, please. Oh, please, next slide. The follow-up is good because at 7 months, the goat was walking without limp, and she has no wound, no plunging ready. And at 10 months, she has no wound, no plundigradia, and you can see the goat in her natural playground. She is close to the mountain, and she is happy to climb everywhere. Next slide, please. Next slide. Thank you for your attention. I was happy to present you this original treatment, and if you have some question, I am ready.
Thank you very much for your presentation.
So I have a comment. Really, because of the strength of this fixation and the strength of now the suture, we have proven that the suture of this prosthesis in the gastrocnemius tendon is very strong. So you have a good fixation in the tendon and a good fixation in the calcaneus. So for me, the goal is to remove the maybe just after the 2 first weeks, and maybe just after the surgery, to remove the bandage. I am sure that it's not necessary to use a bandage, but with the goat, who is always climbing, and she will be with the other goats. At this time, I remember I have preferred to put a bandage, but she was too excited, and she moved a lot. She moved a lot, and really it was maybe the bad idea to let the bandage on the goat when she were with the clients. And maybe I did a mistake at this time.
There is no question for the moment. I think everyone is being shy.
Thank you. Thank you very much.
So, well, if there is no question coming, I will just give a word about IGOS. IGOS Group is an innovation group for orthopedic surgery, and this webinar has been provided by 3 members of IGOS. any orthopedic surgeon can join this group in order to share its experience around the joint surgery. The goal is always to achieve more minimally invasive and physiological surgery, and to challenge the current technology to answer the issue everyone can meet. So do not hesitate to have a look to the IGOS website, I thank again the three of you for your presentation and for your interesting and unusual clinical cases. And I think we can end this webinar now. Thank you very much.
Thank you.
Thank you a lot. See you later. Bye-bye.
Bye.